joining. As Nancy said, this is the roadmap to dementia diagnosis, and we're hoping, Dr. Gad Marshall and I, to leave a lot of time for questions that you may have. I'm going to control the slides, but I do also want you to be aware that a lot of this information is actually in the booklets, which have a lot of resource materials in there. And you can really view us on our website. So hopefully if you want more information, you can get that. So let me start. This section is really going to be on thinking and memory concerns. And then Dr. Marshall is going to really talk about what to do when you go to the doctor and get a diagnosis. I don't think I need to tell this group, but there are many more people living into old age. I remember when I was younger, it was very rare that someone would live to be 100 years of age. And in fact, I remember Willard Scott on the Today Show highlighting those individuals because they were so rare. But now we know that the population is aging, and there are 1.9 million people over the age of 90. That's like hard to imagine. Many of my relatives died in their 70s, and my mom and dad lived to 91 and 93, which was like a phenomenon in our family, and in part because of all the good medical care that is available to older people nowadays. But we also know that there's no guarantee that just because you live longer, you're going to have a healthy, vibrant life. In fact, this slide was put together because I initially was surprised how many people actually had a diagnosis of Alzheimer's disease at the time of their death. Rosa Parks, who was very famous in the civil rights movement, actually died with Alzheimer's disease. I know people on this website will know that who Perry Como is. I asked that of younger people, they don't have a clue. But then even Dear Abby, Ron Reagan, Henry Ford, Eric Erickson. So it doesn't really make any difference who you are, what you've done in your life, how famous you are, that Alzheimer's disease is no respecter of persons. And one of the things that we also know about this disease is that the changes in the brain are occurring 15 to 20 years before someone even becomes forgetful. So if you have a family history of Alzheimer's disease, it really becomes critical to pay attention to the early signs that we're going to be talking about, because there are research opportunities and clinical trials to be able to reduce the burden of that pathology in the brain, hopefully before you even become forgetful. So there are many changes that occur as we get older, and some of them are really related to memory. And it's important to know what's normal memory change in contrast to things that are not normal. So for instance, forgetting names. How many times have you watched a movie and said, what is the name of that movie star? We should not be forgetting the important people in our life, but coming up with names, coming up with words is a common phenomenon as we get older. And in fact, all the women here on the website will know that as we go through menopause, coming up with words and names is even worse. So that's a common feature that we all experience, which is really a part of just getting older. The other aspect is absent-mindedness. What did I come into this room for? Where did I put my keys? Where's my wallet? These are things that also are a part of the normal aging process. Now, on the other hand, if you put your keys and your wallet in the fridge and instead of on the dresser, then that might be problematic. But the normal kinds of things about what did I come in the room for are really a part of normal aging. Also, where did I park the car? So one of the things that I'm going to encourage all of us to do as we get older is to develop compensatory strategies. Always put your keys and your wallet in the same place. Write down where you park the car so you're not looking all over the place for it. I also know that with the new fobs that are on the keychains, I've got friends who just, instead of paying attention to where they park the car, they just hit the alarm so that the alarm goes off and they know where the car is. But these are things that are just part of the normal aging process. But what is a cause for concern that's really not totally related to normal aging? One of the first things that really becomes alarming to people is when you all of a sudden become lost in some place that's familiar to you, or you can't find your way back to a place that is also familiar to you. I had a patient once who couldn't remember how to drive to the mall, and that became a red flag for her to come and get an evaluation. So you should not become disoriented or lost in familiar places. Another thing that is of concern is when you ask a question and then a few minutes later you ask the same thing. This is often very noticeable to family who have to consistently repeat information. And I don't mean just because somebody wasn't paying attention. I mean, the information actually got communicated, it got heard, and still it never got registered. Other things of concern, of course, are forgetting appointments. And even more than that, forgetting to look at the calendar where you put the appointments. So these become concerning activities that you want to pay attention to. And of course, even of more concern are forgetting to take your medicines or forgetting details of conversations or recent events. And then more later on, as maybe our memory problems get even worse, forgetting important birthdays or anniversaries, or forgetting important events from your past. These are not things that should be happening as a part of the normal aging process. On the other end, there are stages of memory loss. It isn't like as if you remember everything perfectly at one moment, and then the next moment, all of a sudden you're forgetting nothing, or you're forgetting everything. That memory changes generally are gradual. It goes from normal to then initial concerns that you might have. People are often very aware when they begin to become more forgetful, and they become a little worried about themselves. Sometimes you become more worried about yourself than your loved ones do. But then when your loved ones also become worried and concerned, that should really trigger you to think that you may need an evaluation. And then your memory problems will progress to mild retrieval problems. And what we mean by that is that you don't have instant access to your memories. They're like on the tip of the tongue, but yet if someone gave you a clue and say, well, don't you remember we did such and such, then all of a sudden the information comes tumbling back. That is a part of the mild retrieval problems that are in early stages of the disease. But then as our memory becomes worse, these retrieval problems become major. This is where you are literally forgetting what you did last week, what you did yesterday, forgetting details of conversations. These things all become really red flags that should trigger us to get an appointment. So if you're worried, or you're worried about a friend or a family member, here's how, it's sometimes difficult to talk to someone with these issues. On the other end, if you have an ongoing relationship with someone, you know that they have a family history, it's important to have these conversations often, where when you do have a conversation about your concerns, it's not going to be out of the blue for this individual. So in talking with a family member or a friend, ask if they notice that they're having concerns about their memory or thinking abilities. Most often, people have some awareness and are also kind of glad that you brought it up. If you're noticing, then give examples of what you're concerned about, and then discuss follow-up care with either your primary care physician or or a behavioral neurologist, like you'll hear from in a few minutes in Dr. Marshall. But you also should remember part of the reason why it's important to get a medical evaluation is that there are some medical issues like infection, medication management, depression, sometimes hypothyroidism, sometimes vitamin deficiencies. These are things that actually can cause thinking and memory problems, and they're entirely reversible. So you don't want to be afraid to get an evaluation just because you're afraid to hear Alzheimer's disease. You need to be very aware that there are some things that we can actually do something about that actually may improve your cognition and your memory. So it's important to have a medical evaluation in order to reverse conditions that are reversible. And then you should also know that many times people with memory problems have mood and behavior concerns as well. They get irritable, and when you see this in a loved one where they are more irritable and anxious and depressed, even though they haven't been open with you about their memory concerns, it may be because they're scared. And they don't want to appear abnormal to their friends. But what usually happens then is they don't want to socialize. They are turning down engagements or dinners that normally they would have gone to, and they're isolating themselves more, which is not a good thing. They're also they may be having sleep problems, and things that used to interest them before, they're less motivated and interested in pursuing them. So all of these things are very early signs of changes that should alert you to the fact that something more serious may be going on. And then finally, from my end, why get a diagnosis? Well, first of all, you want to take charge of your own future. I say this to my patients all the time, particularly those that still have the capacity to make decisions. Decide what you want to do. If you're going to decline in life, where do you want to live? How do you want to live? Where do you want to go? Take charge of your future. You want to be able to maximize your healthcare experience by getting a diagnosis early, or coming into research studies where you might get an experimental treatment that may actually help you or increase your quality of life. Again, as I said before, you could have a medical condition that's reversible, but you should also know that there are many resources and support groups available to you to help you maintain, control, and plan for your future. So having a care plan in place, which is something that will reduce stress for you, understand your research opportunities, and more importantly, you want to build a support network, both for you and for your loved one who may actually be caring for you, so that we can reduce the burden of this devastating disease called Alzheimer's disease. All right, I'm going to turn this over now to Dr. Gad Marshall. Tell me when you want me to increase the slides, and I'll do so.
Okay, thanks, Dr. Rentz, and thank you everybody for attending. So let's move on to the next slide. Okay, so you heard from Dr. Rentz what are the important concerns to note, and let's say you have noted such concerns in your memory, your thinking abilities, some changes in your mood and behavior later in life. You should talk to your doctor about it. You should talk to your provider about it. So starting with the primary care physician, talk about these different symptoms, make sure that you provide additional information from people who know you well. Ideally, they would come to the appointment with you as well. Provide that collateral information. So you may be aware of deficits or changes, but sometimes you're not, or you may just need the support for these appointments. So let's move on to the next slide. And so what happens in the process of getting a diagnosis? So your provider may or may not be able to diagnose you right away. So keep that in mind. It may take several visits or even seeing other providers and particular specialists sometimes. And some medical conditions may be just difficult to identify and again require follow-up appointments. And so let's move on to the next slide. And so who are the specialists? So aside from your primary care physician who will see you initially, there are different providers, a geriatrician who will specialize in old age medicine in a sense, which a lot of primary care is about that, but having more sensitivity to what goes on as you age in terms of different processes, as well as how you respond to medications. Sorry. Looks like Amanda's iPhone. Let's mute that one. Can you be muted? I'm gonna, there we go. No more echo. Okay, great. Thank you. So, I was muted as well for a moment. Sorry. Trying to mute everybody. So a psychiatrist may be necessary if there are mood and behavior issues that cannot necessarily be handled by the, looks like we're getting more background noise, sorry. Simone Carter, okay, muted, thank you. Sorry to call you out, just trying to navigate our background noise. So a psychiatrist or geriatric psychiatrist may be necessary in terms of helping with mood or behavior issues, a psychologist for therapy, a neuropsychologist like Dr. Rentz for helping with the diagnosis with more extensive cognitive assessments, a neurologist or a behavioral neurologist like myself who will also manage the different symptoms. Next slide. And so when you see a specialist, what should you expect? What will happen? So we will evaluate your memory and thinking concerns and your mood and behavior issues. We'll do an exam, a general physical exam, to a lesser extent, more so a neurological exam, and of course the cognitive testing as needed. If more extensive testing is needed, neuropsychological testing will be done by somebody like Dr. Rentz. And after that, we will generally obtain a scan of your brain, and we'll review which scans are commonly used on the next slide in a moment. And sometimes we will recommend a lumbar puncture to look for markers of Alzheimer's disease, in particular in the spinal fluid. It's important to review your medications closely because there are some medications that could actually contribute to cognitive decline. It's important to review your medical history to see if there are issues, again, that can contribute to cognitive decline, as well as your family history to determine your risk. And the question, and then we also administer questionnaires about a variety of things about your cognitive concerns, your mood and behavior issues, and your daily functioning. Next slide. And so here we describe the commonly used scans of the brain, and most commonly we will start with an MRI scan. So a magnetic resonance imaging scan which shows us the fine structures in the brain. And what we're looking for in particular is to see if there is any vascular disease, either strokes or chronic damage to small vessels in the brain that can contribute to cognitive impairment. We're looking for tumors. We're looking for atrophy or volume loss or shrinkage in the brain in a pattern that could be suggestive of a neurodegenerative disease like Alzheimer's disease. But it's important to note that an MRI scan is a magnetic scan, so there are certain contraindications. So if you have any iron-based metal, no more implants really that are iron-based, but if you have shrapnel, which some people have, or if you have a pacemaker, you could deactivate the pacemaker with the MRI. And so it's important to make sure you go through the laundry list of items that are reviewed before a scan to make sure it's safe for you to undergo the scan. You may also be claustrophobic. It is a tight, narrow scanner. It's loud, and so if that's the case for you, you may not tolerate the scan. You may do well if you get a sedative. So it's important to discuss that with your provider before you undergo the scan. If you cannot undergo an MRI scan, A CT scan is a good alternative. It also shows us the fine structures in the brain, not quite as sensitive as the MRI, but does a good job. And it's much quicker and also not quite as confining as the MRI. So those are the scans we typically obtain to start with. Sometimes we obtain a PET scan or positron emission tomography, which uses a different type of contrast to highlight specific changes, in this case in the brain. So FDG or fluorodeoxyglucose basically shows us metabolism of glucose or sugar. So it shows us activity in the brain. And in neurodegenerative diseases, we see a decrease in activity in a pattern that's suggestive of that condition. And so that's something that we could do. That is covered by insurance. The next scans that on the list of PET scans are looking at pathology of Alzheimer's disease with the contrast that's used, either amyloid or tau. And there's several of them that are FDA approved, but unfortunately not covered by insurance, and they cost thousands of dollars. And so we almost never do them clinically. And unfortunately, because of that coverage issue. And so we usually just do them as part of a research study. Next slide. And so after we obtain this evaluation with clinical evaluation, scans, blood work, if we're looking for changes in thyroid function or vitamin deficiencies, as Dr. Rentz mentioned earlier, we may come to a conclusion of this is the cause of your cognitive symptoms, either at the stage of dementia or one of the preceding stages, as Dr. Rentz outlined. And so the most common cause is by far Alzheimer's disease, but other common causes are vascular changes in the brain and Lewy body dementia, which is a sort of Parkinsonian dementia. Less common is frontotemporal dementia, and then there's some rare causes. But keep in mind that very commonly you'll have a combination of these. And so at least 50% of patients who have dementia have more than one cause, which has been challenging in terms of our treatment. But that is something to keep in mind, and we always look for that. And in terms of trying to understand the likelihood of future symptoms as well as potential treatment options. Next slide. So another thing to keep in mind is once you do have an established diagnosis, usually the process is a gradual process, as you heard from Dr. Rentz. So if you have a sudden change, that's actually something that you need to tell your provider about pretty urgently, because it could be that something else is going on. And so many things can cause stress to the brain when you already have a lower threshold because you have dementia or you have mild cognitive impairment. Even just simple dehydration, a simple infection like a bladder infection, side effects from medications, very common. So medications that are used for allergies that contain Benadryl or diphenhydramine can cause confusion. Some sedatives can cause confusion. Opiates can cause confusion. A thyroid imbalance, dehydration, even just not keeping hydrated. So all those things could be a stressor to your brain and make you look much worse temporarily, even to the point of delirium. So for a few hours or a few days or sometimes longer. And so it's important to note that, because if that's going on and you identify what the source is and you treat it, then you will most likely come back to where you were before. And so you should not expect an abrupt decline like that if you have dementia. And so it's important to be on top of that. Next slide. And so this busy summary slide discusses some of what we already reviewed in terms of the initial evaluation. And then once we make a diagnosis, as part of our management, we will make recommendations about medications that may be potentially problematic in terms of causing worsening cognitive decline. So we may advise your other physicians to potentially discontinue them if possible. We will potentially prescribe medications to treat dementia, which unfortunately we have limited benefit from them currently, and we're obviously working on better treatments as part of clinical trials. We will sometimes have to treat behavior and mood symptoms which we initially try to treat without medications by making various recommendations of how to handle the situation. But often you still need to resort to medications. If there's an acute change in your memory, as we discussed earlier, you may need to treat that differently. And then it's also important to plan for the future. And so we have discussions about supervision that's adequate for a person to be safe in their environment. We discuss assigning healthcare proxy and durable power of attorney, exercise and healthy diet, and social stimulation. And then we also talk to the care partner in detail about how they're doing, because that's another full-time or more of a full-time job that you're engaged in when now your loved one needs your attention much more than they did before to care for them. And so that could be quite burdensome in many ways. And it's important to educate the care partner, important to make sure they have access to various resources and respite and support. And so I think that is my last slide. So I'll hand it back to Dr. Rentz, and we will talk more because we have a lot of time for questions. You are still muted, Dr. Rentz.
Yeah, I know. I couldn't get my cursor to work. All right. So I wanted to just let all of you know rather quickly is that we have resources available no matter what stage of aging you happen to be in. This one is the Roadmap to Dementia Diagnosis. You can get all of these booklets on our website at madrick.org. We have a booklet on research participation. What does it entail to join a research study? We have Roadmap to Caregiving for those of you who need more support in your caregiving activities. And then we have Roadmap to Prevention, Roadmap to Behavioral Management as symptoms become more severe, and also the importance of social engagement. So we also have a roadmap to social engagement as well. So all of these books are free of charge. You can download them and send them to friends and family. They're in PDF form. For those of you who are at other facilities, feel free to use these as you see fit. In fact, the National Institutes of Health have actually recognized the importance of these booklets. So we're very lucky to have them available to you. But what if you want further treatment or you want to get engaged in research? Here's the Center for Alzheimer Research and Treatment that Dr. Gad Marshall and Risa Sperling run. I'm a co-director of this. We have a lot of studies that we're engaging in, and one of them is actually a prevention study run by Dr. Sperling called the AHEAD study. And this is for people 55 to 80 years of age who don't yet have serious symptoms of disease, but have a family history. And it's all with the intent that if we treat early, the pathology in the brain, could we ever keep people from ever declining into memory loss and dementia? So look at the website. You'll see many of these studies listed there. We also have our MGH partners are doing even more innovative studies at the Alzheimer's Clinical and Translational Research Unit. I'm encouraging you to look their studies up. What happens is if you get in touch with us and you don't qualify for one of our studies, we will definitely refer you on to some of these other studies too. If you have more frontotemporal dementia, there's an entire unit at the MGH run by Brad Dickerson, who provides diagnosis and support and caregiver support for people with this disease. And we've heard a lot more recently in the news about Lewy body and Parkinson's disease. Dr. Steve Gompertz over at the MGH also runs a unit and some clinical trials to treat this disease as well. And then finally, there are a lot of people who have vascular problems or vascular disease. And Dr. Anand Vishwanathan is the one who runs a lot of the vascular studies at MGH. Again, you can find all of this information on our website. And I would encourage you to take a look. And then finally, I want to just thank everybody who participated in putting all these booklets together. All the resources have been updated. The telephone numbers have been updated. So hopefully you will get up-to-date information should you need it. And here is additional questions. We encourage you to contact Lenore or Nancy, who can answer some of your questions. If you'd like to schedule a memory test, Claudia Valenzuela is available. Again, all of this is on our website. And then if you want to be on our list to receive quarterly newsletters and greater program information, Christine Brown is available for that. The whole point of saying all of this is we want to be there for you. We want to be able to give you the support that you need. We know that receiving a dementia diagnosis is not an easy thing. And as we all get older, we have a greater proclivity to developing some of these diseases. So we just want to know that we are your home for research and for care. And I think that's it. I'm going to stop sharing so we can see everybody.